So you can go.
Cool.
Perfect. Okay. Hi, everybody. Thank you so much for joining us this evening. Just a couple of quick housekeeping announcements, and then we will pass the mic over to Dr. Curtis. So my name is Brooke Beelman. I'm the Director of Marketing and Communication here at Tim's Medical, and just wanted to go through a couple of housekeeping items in regards to ASHA, CEUs, and PDHs. So this is a little bit different than previous webinars we've had, where you will complete the survey like you've done for previous events, but it's all linked through Zoom. So you'll just access that through the registration link. And if you have questions, I'll pop my email into the chat so you can contact me with further questions. And you'll have from today until next Wednesday evening to complete that for ASHA CEUs. And then if you want PDHs, I will again put my email in the chat so you can email me directly for a customized certification that will be sent to you. And with that, I'm going to hand over the mic to Dr. Curtis. This webinar is being recorded, so if you miss anything, don't worry, you'll be able to access the replay on our website within 48 business hours. So Dr. Curtis, over to you.
Great. Thank you very much. Let me go ahead and share my screen. Brooke, maybe just give me like a thumbs up or a yeah, we see your screen situation.
Yeah, we can see it.
All right, perfect. Great. All right, well, welcome everybody to this webinar on the visual analysis of swallowing efficiency and safety, or VASES. I'd just like to begin by thanking Brooke Beelman and Tim's Medical for the invitation to speak with you all today about this topic, which is near and dear to my heart. Also exciting that you might get some ASHA CEUs for this. I posted about this on my social media and put PhD. Unfortunately, you don't get a PhD for this, so my apologies. So yeah, let's go ahead and get started with some disclosures, which is that I'm a salaried employee at Cornell University's Medical Center. I am being paid an honorarium to speak with you all today, so thank you, Tims, I appreciate that. And I'm also a co-author and co-developer of VASES, so maybe some biases in there, but I think that they are well-founded, but otherwise no other relevant financial or non-financial disclosures or conflicts of interest. In terms of a little bit about me, I'm coming and speaking to you all today from New York City. It's about 8 p.m. at my time, or like 20 hours. I don't know how people say that in like the 24-hour system, but it's 20 hours. I am an assistant professor of speech pathology at Cornell Medical College of Cornell University, and there I do a mix of both research and clinical, more on the research side, but I do have some time working clinically in the Department of Otolaryngology, head and neck surgery. I work with a really great team of research assistants, graduate interns, of clinical fellows, of colleague speech pathologist. In the middle of the screen on the top, we have Dr. Anais Rameau, who's a laryngologist who specializes in dysphagia that I work with. And just below her, we have Valentino Mochetti, who's one of the dysphagia SLP specialists. And so I really work with a really amazing team, both within the department and also in kind of extended affiliations. A little bit about you all. So this is really exciting. As of a couple of hours ago, we have registrants from around the world. This is really exciting for me to see. I'm pretty passionate about free online medical education. And so I think it's really great that Tim's is, and I'm not being paid to say this, but I think it's really great that they have this webinar series that they're making freely available to all of you. And I think the fact that there's so many registrants here speaks to how free education really makes things much more accessible, and hopefully, I think, impacts you, the clinician, and ultimately the patient. So go free education, not to get too political. In fact, we have over 540 registrants from 26 different countries. So in just a minute, I'm going to do a few polling questions. I think there's about 6 polling questions right now, and then a couple sprinkled in the rest of the presentation. So go ahead and grab out your smartphone. This first question is just for people in the United States right now. You can scan the QR code, or you can, on the top left, you'll see a website on polev.com/JamesCurtisSLP. Log in and go ahead and answer this. When you log in, or when you scan the QR code, you might receive a message that says register for credits or cred. You can just click skip for now. And you should be able to start to answer these questions. I'm working in a dual monitor situation, so I can only see the results over here. So glad this is working. It's my first time using Poll Everywhere. Seems like it's a good resource if you have it as part of your institution. We'll just wait another 10 seconds or so. All right, we have even split of Southeast and Mideast. That's great. I originally hail from the Great Lakes, so but there we go. Getting some more Great Lakes in there. I like that. I like that. All right, let's wrap it up in 5 seconds. 4, 3, 2, 1. So this is really exciting. Seeing people throughout the United States, which is a pretty big country, in addition to throughout the world. I couldn't figure out how to do a polling question with all the countries, so my apologies. I'm not trying to be exclusionist there. All right, moving on to the next poll. If I can. Seems like it's kind of frozen. There we go. All right, what is your primary professional role? Some of us might straddle a couple of professions right now. Pick the one you work the most in, or maybe identify the most with. Okay, so most people being SLPs, we like that. A couple of clinical fellows and graduate interns in there, we like that as well. We like everybody. The more the merrier. So, all right, next poll. How many years have you been performing and or interpreting fees? So 0 should be just like less than 1 or 0. This is really great. We're having a really nice diversity in terms of the people who are here geographically, in terms of people, in terms of their experience levels. Looks like most people are kind of on the newer side of performing and interpreting fees. So this is great. It's getting you off on a good start, hopefully. But people throughout, wow, people doing fees more than 20 years. This is awesome. Go you. All right, this is kind of a true or false situation, or how much you agree with this. So kind of coming into this is going to help me understand where we're at. I have a generally good understanding of why and how to use VASES in clinical practice for fees interpretation. So I have a generally good understanding of why, but also how to use it. Okay, so we call this skewed data, right? We call it positively skewed. Most people are on the left side of the scale. Throwing in some research right there. All right. All right, so most people are coming in not knowing much about it, or at least in terms of why you might be interested in using it or how you can go about integrating it into clinical practice. So great, this presentation is designed for you. Hopefully we can shift that a little bit to some extent. Do you currently use VASES to interpret fees? Yes, no, I hate it. I'm a little skeptical, or no, but I'm kind of interested. I'd like to learn. I'd like to be able to. Okay. I'm all about healthy skepticism. As long as we can have like actual conversation, right? That's how we should live in real life as well. We should feel comfortable with feeling uncomfortable and have respectful, open communication with each other. Colleagues, friends, frenemies. Okay. All right, last poll question. For those of you who currently perform and interpret fees, what scales do you currently use? Lots of people doing the PAS. It's great. It's great. It's been around for a while. We got some digest fees in there. We got some Yales in there. We got some other validated rating scales. Go ahead and put those in the chat. I can't see them, but maybe Brooke can let us know towards the end. Would be interested to hear what those are. The pooling score, the P-score, that's one I think that's done a lot more in Europe. Mansura, recently published a few years ago. All right, so most people using the PAS, looks like with some Yale fringe residue rating scales in there, and then maybe some digest fees, maybe one or two VASES. All right, that's no problem, no problem. All right, so let's go ahead and get started. Now that we kind of have a general understanding of where we're all coming from here. Okay, so just to kind of get us started off, FEES is an instrumental procedure that's frequently used by speech pathologists and maybe some other disciplines as well, including certainly otolaryngologists here in the States, maybe neurologists in Europe, to aid in the comprehensive assessment of swallowing and swallowing disorders. And it's been around for a while, and it's really considered to be a clinical reference standard for bolus-related outcome measures. Now, this goes by a variety of different names. It was first published as fiber optic endoscopic evaluation of swallowing, and since has many other names associated with it: flexible, functional, video-endoscopic swallow studies, video-endoscopic evaluation of swallowing. I'm sure there are a lot of others out there. The term I use is flexible endoscopic evaluation of swallowing. It would be awesome if we slowly became a little bit more standardized in just the term for the test. This is because, you know, when this was originally published, most of the flexible endoscopes out there were fiber optic scopes. And many of the scopes nowadays don't have fiber optic cables or don't really rely on them. They have distal chipped cameras. And so flexible is just a little bit more of a catch-all nomenclature that's relatively correct. I also like it. I kind of come from the voice world a little bit, where very frequently people will use rigid endoscopes. And so it kind of helps to differentiate and kind of stay within that realm of rigid versus flexible. So a term for you to consider using. So many of us who perform FEES, we routinely provide ratings of a pharyngeal residue, penetration, and aspiration as part of our standardized practice patterns. To make judgments about pharyngeal residue or pharyngeal swallowing efficiency, it's common for many people to use categorical ratings of none, mild, moderate, severe, or maybe some other kind of breakdown of categories, but categories like this. And to make judgments about swallowing safety, it's common for many of us to use the 8-point penetration aspiration scale. In fact, we just saw that over half of you are currently using that in your clinical practice. And if you're using also something like digest fees, the penetration aspiration scale, or the PAS, is actually integrated into it. We're going to continue with this in a second. I just had a side thought, which is that if you have questions, we'll probably save most of the questions to the end. It's possible I'll go a little over 60 minutes. I'll try not to. But Brooke will be kind of moderating questions a little bit. And I might take questions here and there throughout, but otherwise most of them will be saved to the end. Okay, so let's say you and your colleagues have worked to really kind of improve standardization within and also amongst yourselves, and you use these measures of pharyngeal residue and then the PAS to document your FEES outcomes. All right, so let's say these are the measures that you're using. I'd like to take us through a quick clinical case, something that's not too all uncommon. So let's say that we have a 62-year-old male with a 6-year history of Parkinson's disease. I'm going to be polling you in a second. And the patient completed a 4-month course of swallowing therapy. Okay, so 6-year history of Parkinson's, and there was a swallowing disorder there. So we went through a 4-month course of swallowing therapy. Now, let's say halfway through the therapy, so about 2 months after the start of therapy, we completed a FEES, and then we also completed a FEES immediately after the whole block of therapy. So we started therapy, 2 months later we did a FEES, and then another 2 months later, 4 months total, we did another FEES, okay? And let's say there was no difference between those two FEES exams. Because there was no difference in these FEES findings in the reports that we were reading and seeing, the patient was interested in maybe transitioning to more of a maintenance program. So maybe their health has been relatively stable. It doesn't seem extremely critical, right? And so we're like, let's just kind of keep you where you're at. Let's try to maintain the slight gains that we've made. And so that's the plan. Let's do a maintenance program and let's see you back in 6 months. And see kind of where you're at and kind of repeat the assessment and figure out kind of where to go from there, okay? So this patient returns to us 6 months later, after we've transitioned to the maintenance program, after we stopped that 4-month course of intense therapy. And they come to see us for FEES, and they report that the maintenance, they've been doing the maintenance as we recommended. They report no change in health status, nothing like pneumonia or malnutrition. Their health has been relatively stable, okay? All right, so keeping that in mind, let's say this is what they looked like immediately after the therapy, so after those 4 months, right? So let's say these are kind of the primary findings, was that there was moderate molecular residue on 2 out of 2 pudding bites. We saw penetration into the vestibule, but not further down, and it wasn't ejected. So that would be a PAS of 3 out of the 8-point scale. And we saw this on 3 out of 6 thin liquid cup sips. Let's also say that we saw 1 event of silent aspiration. That's a PAS of 8. So that means something went below the vocal folds into the subglottis, and the patient didn't cough or throat clear in response to that. And that happened on 1 of the 6 thin liquid cup sips. So this is where they looked like immediately after we finished therapy, before we transitioned to the maintenance program. Now, they come back for their 6-month follow-up, and this is what we see. We see moderate molecular residue on 2 out of 2 pudding bites. We also see penetration into the vestibule that's not ejected, so that same PAS of 3. This time it's on 2 out of 6 thin liquid cup sips instead of 3. And we saw another event of aspiration. This time it was non-silent, so this would be a PAS of 7. And this occurred again just once. All right. So I'm going to ask you a couple of questions. Absorb this material. This happens to us in the clinical world. This happens to me all the time, unfortunately. Okay, so is this patient's swallow function changing? Now, I like to say that in clinical practice, I would love it if we knew conclusively, right? We do our swallow assessments, and it's great if we know conclusively what's going on. But the reality is we don't. All we do is try to make best guesses. That's at least how I view things. And we want to set ourselves up to make these guesses as good as possible. So I don't know. Maybe they're a little bit worse, or it seems like they are probably relatively stable, or I don't know, but maybe they're a little bit improved. Hard to say. Okay, so we have most people, the majority, thinking that the person's relatively stable. And then another large chunk of people, to a lesser extent, saying maybe improved. So if this was like a group of like 10, I'd have us talk right now, but it's not, and that's okay. This is great, actually. So I'm going to go ahead and think that the reason we're thinking that they're relatively stable is because the molecular residue was essentially the same. There was a PAS of 3 on both times. One time it was like 3 trials, and the other time it was 2. So it's like, I don't know, it seems like it's maybe just normal variability. And it seemed like there was 2 aspiration events. I'm guessing some of you who thought that maybe they were a little bit improved is that they were no longer silently aspirating. And maybe that 1 less event of PAS of 3 was important, right? Yeah, I don't have an answer. I would like probably not answer that question. But I'm straddling between what you all are thinking right now. If that's like what we had on reports, that's where my mind would be at. Okay, given that, how would you proceed clinically? Okay, this is the decision that you make with the patient, right? The patient is the center. Let's assume the patient is still interested in that maintenance program. And you are interpreting the fees and trying to figure out what would you recommend as kind of a guiding by the side situation. We're not telling the patient what to do, but we are kind of giving our advice and what our thoughts are. Love it. Love it. I agree. I mean, I think the patient's health has been relatively stable. They're motivated to keep going with the maintenance program. They kind of plateaued. So who knows, like if we were selecting the right exercises or what, but they're maintaining seemingly. And so given the fees information that was provided with us, it seems like they're okay to kind of keep maintaining, continue this maintenance program, maybe see them again in another 6 months. That's probably the way I would go with things too. So would your impressions and would your clinical recommendations change if the following information had been provided on these reports? Immediate post-therapy, right? This is right after those 4 months, they had moderate molecular residue, but this time it was characterized by about 25% of the molecula being filled with pudding residue. And this happened on both pudding bites. Let's say they had the PAS of 3 on those 3 out of 6 thin liquid cup sips, so penetration into the vestibule, but not lower down. And it was a super small amount. It's covering like 2 to 8% of the laryngeal vestibule, super small. And they had silent aspiration again on that one trial, but again, it was a really small amount, covering about 2% of the subglottic shelf, okay? Now, let's say 6 months later, they come back for the fees, and this is the information that we're seeing. Moderate molecular residue, but this time, 50% of the molecula is actually being filled with these puddings. The penetration occurred only twice, but now when it occurred, 70 to 80% of the vestibule was covered. And the non-silent aspiration event, while good that they were responding to it, it's seemingly because a lot of the subglottic shelf was covered. It was a lot of aspiration that presumably occurred. And in fact, this is something that we've seen in research that we published, is that people are more likely to have silent aspiration when it's a super small amount. And when we have lots of aspiration, that's when people seemingly cough, people with neurologic disease, such as Parkinson's. So I'm going to ask you these questions again now. This is the information that you're provided with. Now, with that information, what do you think about their function? Are you not quite sure, but maybe they're worsening a little bit? Does it seem like they're relatively stable? Or are you not quite sure, but now thinking they're a little bit improved? "101% sometimes." Okay, was not expecting 100%. I'm glad this case worked as a learning point. Yeah, I think like I would be counseling them a little different in terms of what I thought was actually maybe happening, right? Beyond this kind of intellectual exercise, what would we do clinically at this point? Would we say, yeah, continue with the maintenance program, or would we be more inclined to be like, look, we know you want to, and your health has been relatively stable, but we think your swallow is declining, so maybe let's do another booster course, maybe not for 4 months, but maybe for a couple of months, and kind of get you back going. Yes, okay, great. So what I'm trying to highlight in this one case example is that using measures for fees, or really any assessment that we do, we should be incorporating measures that are responsive. And so this means, I used to use the term sensitive. So we're able to detect changes when changes are actually present. They're valid, meaning that it's measuring what we're intending it to measure, and also reliable. So we're going to get the same measure every single time. So the measures that we're using, or the scales that we're using for any assessment, including fees, should be as responsive as possible, as valid as possible, and reliable as possible. And in this case, we saw that they weren't really responsive, quote unquote, right? So we saw that the molecular residue was characterized as moderate both times. And in fact, in some scales, moderate goes from 25 to 50%, right? So there was a change that was actually happening, but we weren't really communicating it. I would say that in terms of using it, in this example, just the PAS, the PAS is valid. It's talking about the depth of and reaction to penetration and aspiration. But clinically, when we're thinking about penetration aspiration, we're probably also wanting to capture amount as best as able, right? And so while we're using the PAS to talk about swallowing safety, it's not really getting at that construct completely, right? And so maybe we want to augment it with another type of measure that tells us the amount, not just where it's at and if someone's coughing. And so I would argue that relying just on the PIS may be a little bit less valid than we actually think. And then certainly we want measures to be reliable, meaning that if we look at that the same fees a week later, we looked at it back again, we were coming up with the same results, right? Or I see something and then you are seeing something very similar and not something that's very different. So these things you might see in research, but it has it's really important clinically, right? It has immediate clinical impact on how we're interpreting assessments and ultimately what we're recommending for our patients. Okay, so in order to start to think about which measures are kind of responsive, valid, and reliable, and I should say no measure is perfect, including VASES. Everything has benefits and limitations. And you as the stakeholder, as the clinician who's using different scales, should be well aware of what the benefits and limitations are. And I think part of it involves understanding the diagnostic advantages and limitations of our assessments, including fees. And so to think about the diagnostic advantages and limitations, I think it's helpful to kind of start off with understanding some basic standardized terminology, just kind of getting us all on the same page. So when we think about swallowing in general, we have swallowing physiology. We say that term all the time. So swallowing physiology, or really just physiology in any sort of movement in general, can be characterized by two different parameters, kinematics and pressures. So kinematics, we could be talking about walking, we could be talking about picking up a cup of coffee. It's really any movement, and swallowing is no exception. So kinematics is just a fancy term that's used in movement sciences, and it refers to the movement of structures without considering the forces or pressures behind those movements. So when we're using our eyes to watch someone walk, or we're using our eyes to watch someone pick up some coffee, or we're using our eyes to look at video fluoroscopy, for example, we are doing a kinematic analysis because we're looking at the movements without actually knowing the pressures and forces behind those. Kinematics can be further subdivided into two parameters. Spatial kinematics, which refers to kind of the morphology at rest, like how a structure just looks at rest. We can also think about how far it moves from point A to point B. So we'd call that displacement. It moved 20 millimeters. We can also think about like peak position. So kind of at the height of its movement, how far was it away from something else? It might have started here and only moved a little bit, but it's actually really far from something else. So we can think about kind of resting morphology. We can think about displacement. We can think about peak position. These are all spatial kinematics. If you're using things like video fluoroscopy and you're talking about reduced base of tongue retraction or reduced frontal stripping wave, those are all spatial kinematic parameters that you're talking about, right? The other element of kinematics is temporal kinematics. So this refers to timing. So the onset of a movement, the offset of a movement, the sequencing, so when did it move relative to when other things moved, and also the duration of movement. I think in speech pathology, we perhaps don't think about temporal kinematics as much, but they are critical and they explain a lot of why people have impairments. I think part of the reason we don't think about it as much is because it's harder to assess in real time, right? We kind of have to do more like frame by frame clicking to really get a clear sense of sequencing and durations. I also think that many of the scales that we use in clinical practice, maybe something for like video fluoroscopy, most of these scales focus primarily on range of motion or peak position and less so on temporal kinematics, although that's changing with things like aspect, for example. Okay, so physiology is also characterized by the pressures behind it, right? So how much force or strength can someone generate during these movements? And just like kinematics, this can be further broken down, and we can think about the magnitude, so how much pressure is being generated or how much they're relaxing, and also the timing of these pressure events. So, just looking at someone, we don't know if they're weak. We shouldn't use those terms if we're not using manometry, because we can't actually assess that. We can look and say that there's reduced range of motion or, reduced duration of movements, but we have no idea if they're actually weak or not without measuring the pressures. So the physiology of a swallow ultimately leads to functional swallowing outcomes. So I use this term because in movement sciences, again, any sort of voluntary movement that we do, it's what we can call being goal-directed, or it's goal-directed and there's a function behind it. We're doing the task for a reason. So if I was to talk about taking a sip of coffee, because it's 8:30 here, which I'll do. We could do a kinematic analysis. You could do a video recording and you could measure kind of the angle of my wrist, how quickly I brought it to my lips, how far my hand and arm and wrist moved for things. But the function, the goal behind this is to get the cup from the counter to my mouth without spilling, right? That's what I'm trying to do. The kinematics and pressures explain how I got there, but I'm doing this movement for a very specific reason, which is to take a sip. And so any movement that we do that's voluntary has a goal behind it or a function behind it. And again, swallowing is no exception, right? We can characterize it all we want, but we're trying to get food and liquid from the mouth and into the stomach. And we're trying to do it in a way that's safe. And when that's impaired, we're said to have airway invasion, right? So that would be the functional impairment. And so airway invasion can be broken down as penetration or aspiration. We also want to do it in a way that's efficient. And so when that's impaired, we're left with residue in the oral cavity, the pharynx, the esophagus, and then that can lead to other things like regurgitation, for example, or maybe post-swallow aspiration, right? So maybe some of these terms maybe you disagree with them, maybe penetration doesn't mean that they're not safe, but these are terms that are becoming a lot more standardized with the development of things like digest, which I highly recommend you look up. And so these are kind of the terms that we're starting to use in the field in a very standardized way. And this is in fact what we try to do when we're eating and drinking. Okay, so knowing that now, quiz time. What are the diagnostic advantages of fees? So when we are doing fees and we're making our assessments, what are the things that we're commenting on in our reports? Because presumably those are the things that we're highlighting and valuing. So what are the things you're talking about in your reports when you perform a fees? It's also likely I'll go like 15 minutes over. I'm so sorry. And then I'll stay on for questions and stuff. Okay, so we'll wrap this up in 10 seconds. All right. And let's go ahead and stop there. So we see that a lot of people are and you can select all that apply, obviously, but that certainly we can look at things like pharyngeal residue, penetration, and aspiration. Most of us definitely agree with that. It looks like another heavy chunk is looking at swallowing kinematics, so kind of describing the movements that we're seeing during fees. Maybe we're talking about swallowing pressures, saying something is potentially weak. Maybe some oral residue, esophageal residue. Great. I'm going to go out on a limb and say that some of these are incorrect. I'm going to go out on a limb and say some of these are incorrect. So we'll learn about this in just a minute. I would say that the diagnostic advantages, what fees is good at, is looking at pharyngeal residue, penetration, and aspiration. I would think the rest, it's not good at. And in fact, I don't really comment on those in my reports anymore. I used to. I think it's really important to always be thinking about kinematics and pressures, but it's not what fees is actually good at. And so it's something I don't really talk about as much. And we're going to get to that in just a second. Hopefully you're not like, what did we just get ourselves into? Okay, so diagnostic advantages. When we think about the diagnostic advantages of fees, and we think about its limitations, we can look at research that compares fees to what was traditionally considered the gold standard, which is our modified barium swallow study or a video fluoroscopic swallow study. Again, that goes by 1,000 names. And so when we compare these two exams, we can look at a couple of different parameters. We can think about swallowing kinematics, right? And the reality is that there's not a lot of research looking at swallowing kinematics as seen on both fees and fluoro. The best study that I know of, which is only one of a couple, is the study that was done by Dr. Jerry Logeman and colleagues back in 1998, so a long time ago. So Dr. Logeman, she was of course an SLP, she was at Northwestern. And so what she did here was she gathered a group of clinicians and asked them to evaluate a variety of different kinematic events as seen during a simultaneous fees and fluoro. So a scope was in someone's nose as the video x-ray was going on. And what we're looking at here, on the leftmost column, we see the kinematics. Where's my, so we see kind of things, some of them are bolus related. So someone could argue that it's not, but looking at laryngeal elevation, epiglottic movement, hyoid movement, laryngeal vestibule closure, right? So these are our kinematic events. And then what we're looking at subsequently, the other columns, is how often the clinicians identified the onset of that movement, the offset of that movement, and the total duration of that movement, okay? The numbers that we're looking at is the frequency with which the clinicians saw this on fees specifically. So if a number says 87.5, it means that 87.5% of people said they saw that event on fees, right? If it said 0%, it means no one saw that on fees. I've also color-coded this so that black numbers represent the event was seen more often on video fluoroscopy, on X-ray, than it was on fees, whereas the red numbers represent that the event was seen more often on fees than on fluoro. That would be a good thing. So what we're looking at here are a bunch of black, right? Meaning that the event was seen more often on video X-ray than it was on flexible endoscopy. So that would suggest that for a lot of these movements, we're more likely to see it if we took them and did an MBS than if we did a fees. So that's not a good thing for fees. We also see a lot of zeros, meaning the event was never seen on fees, which is not good. We do have some red, right? So when we have things like medial movements of the arytenoids and or vocal fold closure medial movement, we do see that these events were seen more often on fees than on fluoro. So that's a good thing. But what I'd like to draw your attention to is that most of these are still less than 50%, right? Only 2 of them were above 50%. And that's just the onset of a movement. It's not even like actual completeness of the movement. So this is not good. It means that a lot of these events we are not like objectively seeing. I suppose what a lot of us are doing in clinical practice is making educated inferences based off of residue patterns. But the reality is that those are guesses. They're not objective pieces of information that we're not seeing. I say this because as an earlier clinician, one of the first places I worked, I was fortunate. I was in a otolaryngology department, and most of the patients that we saw got both fees and fluoro. And I was trained to always think about swallowing physiology and comment on about physiology on both of my reports. And I thought I was a darn good interpreter of fees. Then I go on and do my PhD and postdoc, where we had at the time access to only fees, and we had to refer out for video fluoroscopy. And I was in a research lab, but it was a clinical research lab. So we were evaluating patients every day, kind of like it would be in clinical practice, and then potentially routing them to treatment studies. And I would be training graduate interns and clinical fellows on fees interpretation. And we would be commenting on physiology and making our best guesses. And in some cases, we really wanted video fluoroscopy for them. We felt it was crucial, really crucial to have. And so we'd send them out for video fluoroscopy, and they'd come back, and it was nothing like I thought it was going to be. And so I think what it was really kind of starting to show me was not that I was a bad clinician, not that I was terrible at interpreting things. I think it showed that I had a lot of like confirmation bias that had been developing when I was doing these two exams. And I really had to kind of take a step back and open myself to the possibility that while I wanted to talk about physiology for fees, it wasn't necessarily what I don't think should be doing. And that's because we would be creating treatment plans based off of the physiologic impairments we thought were actually present. And so I think if we're making statements about someone's physiology and we don't actually see it, we could be putting people off on the wrong path for treatment and wasting healthcare dollars, wasting patients' time, wasting our time, which might mean that there might be more of a caseload building up because we're still with other patients. And especially for doing fees and sending these reports off to people maybe in skilled nursing facilities or home health, they're going to be taking our reports as gold. And so it's not to say that we shouldn't comment on physiology at all, but I will say I personally only comment on physiology in my impressions sometimes. And when I do, I make it very clear it is an educated guess. I'm like, based off of these patterns, it is potentially possible that this is due to X, Y, and Z, but it could be other things, right? So I'm giving people kind of a starting block until we get maybe more information, because I want other clinicians and patients to be open-minded that it might not be what I thought and that we need objective information to know. Okay, so does this mean that fees stinks and we should never do it? Absolutely not. This brings us to the next set of comparisons, which is comparisons to functional swallowing outcome measures. There's a lot more research which has been used to compare fees and fluoro. On the left, we see these non-simultaneous Cs and modifieds. So Cs would be a rigid endoscope that goes through the mouth before and after swallowing. In the middle column, we have a bunch of studies that were done where they looked at non-simultaneous fees and fluoro. Typically, the fees was done first, and then a few hours, maybe sometimes days or weeks later, an MBS was done. And on the rightmost column, we have the strongest research designs, which are the simultaneous fees and fluoros, meaning there was a camera in place while the video X-ray was going on. And so I, spent a lot of time looking at this literature and looking at kind of what were these findings showing us. Most of them, that wasn't the aim of the study, but a lot of them still had descriptives in terms of what was seen on both exams. And so I went ahead and kind of compiled to this. So this is kind of a mix of descriptive stuff and also maybe some more like formal stats. And what we see is that generally speaking, there's good to excellent agreement between both fees and fluoro. This is a good thing. So this means that when we saw, let's say, aspiration on one exam, we likely saw aspiration on the other exam as well. Or when we saw pharyngeal residue on one exam, we likely saw on the other exam as well. This is good. We want there to be good to excellent agreement. However, when there was disagreement for these outcome measures, fees tended to have the edge. Fees tended to be a little bit more sensitive. So when we look at pharyngeal residue, I should say that in this kind of that second row or the first gray row, it would indicate that the event was seen more often on fluoro than on fees. In the middle column, it'll mean that they were the same. And on the bottommost row, we had that the study said that fees saw something a little bit more frequently than the video X-ray. And so we see that of the 18 studies that were had reports about pharyngeal residue, 61% of them identified that pharyngeal residue was present more frequently or more severely on fees than fluoro, with kind of an even distribution of the other studies reporting either the opposite or no difference. So much more weight kind of on fees seeing things more often. Penetration, it's probably the most convincing data. So here, 82% of the studies found that fees reported penetration more frequently than the MBS. And then aspiration, kind of a similar situation as pharyngeal residue. Half the studies reported that aspiration was seen more frequently on fees than fluoro. And the other half was not the opposite. It was kind of split between either no difference or the opposite. So the data really kind of shifting and saying that when there was disagreement, fees appears to be seeing things more often. I then came across a meta-analysis which came up with the same results. So that's good. So when we think about the diagnostic advantages of our different swallowing assessments, I'm going to go out on a limb and say that there are gold standards. I think we're taught now to no longer say gold standards don't exist. I would say they do exist. I think we have to be more specific about what we're talking about when we say gold standard or clinical reference standard. They're kind of the very similar concepts. So I would say if we're trying to talk about kinematics, there is a gold standard or a clinical reference standard, and that would be modified barium swallow studies, right? For most kinematic events, exception being maybe medial movements of the vocal folds. Okay. None of the exams talk about pressures except for high pharyngeal residue, resolution pharyngeal manometry or just pharyngeal manometry, right? So no exam talks about pressure, which means we probably shouldn't say someone is weak or strong with their swallow unless you're doing manometry, because we're not actually measuring that. We're looking at range of motion, we're looking at duration, but we have no idea if they're weak or maybe too strong and ill-sequenced. And then I'm going to go out on a limb and say that fees is probably the gold standard if we're looking at pharyngeal or laryngeal functional swallowing outcomes, right? It doesn't look at the oral cavity, so it's not a gold standard for that. And it doesn't look at the esophagus, so it's not a gold standard for that. But for the pharynx and larynx upper airway area, I would say it has the edge. It's probably the gold standard. So with that, there's been a lot of scales that have been developed over the years, which kind of get at pharyngeal residue penetration and aspiration. But I would say that there's been historically some gaps in these scales. A lot of the scales used categorical rating methods, which we saw in the clinical case example, and we know from some really great research by Dr. Jessica Pesena, who's up at Boston University Medical Center, that these categorical rating methods are less sensitive or responsive, and also less reliable. This is not good. I would argue that some of these categorical rating methods are also less valid, right? So if we're thinking about pharyngeal residue, I like to think about this example. Let's say this is a cup, right? And here the cup is empty, it's a glass cup. Residue doesn't, let's talk about this, let's pretend this is the vallecula, right? And we're filling up the vallecula with water or residue. The water in the cup doesn't just dump from nothing to being 25% filled, to being 50% filled, to being 75% filled. Water can fill the cup to any amount. So why create these arbitrary cutoffs when it can really be anything? It could be 5%, 7%, 8%, 9.9%. Like it could really be any gradient, and it's not just these categorical chunks. I'm going to skip that. So I would also say that some of these categorical rating methods are less transparent. So we might be using the same words, but they might mean different things to different people, and we might have no idea that we're interpreting these words differently. So if we just look at the word mild, for example, if we're talking about mild amount of residue, we can see that for one scale, mild is defined as shallow to low pooling. For another scale, it's less than 10% of a bolus remaining after UES closure. For another scale, it's 5 to 25% filling. For another scale, it's less than 33% filling. For another scale, it's less than 50% filling. And so we might be saying mild, but depending on how we trained and what scale we might use more, we might be talking about vastly different things. I might be thinking 5% in my head, and you might be thinking 45% in your head. And if we're not actually saying these numbers, we could be coming up with different impressions and ultimately different clinical recommendations. Historically, there had been no fee scales while they talk about things like molecular residue, puriform residue, or they talk about like penetration in the vestibule or aspiration, they weren't really clear anatomic or temporal boundaries. There was no like method that clearly said, okay, draw a dot here, here, line here, circle this, that's one structure, this is another structure, and now we can talk about residue penetration and aspiration. So for example, if we just look at the term, or if we look at the anatomic boundaries for penetration, here in yellow, we have all the different, this was me going through literature and just kind of scantily looking at stuff. And these are the different anatomic boundaries that people use to define penetration. We can see kind of in this top chunk, it's kind of these larynx or airway, which is kind of vague on these, I would say. We go a little bit lower down and we're including part or all of kind of the floppy part of the epiglottis. And then we go lower down and some people don't talk about the epiglottis and it's just the vestibule, however you would define that on fees. And so you can imagine if these people aren't including the epiglottis penetration, they're going to be reporting penetration less frequently than these people who are saying anything on the epiglottis is penetration. And so if a patient gets a FEES with us and then they go get an MBS later and now they no longer have penetration, we don't know if their function changed or if we're just using different concepts of what penetration is based off of the exam type, which really should not be the case. So if we look at these images side by side, right, if in the gray there was residue, on the left, I don't think many of us would say on that X-ray image that that's penetration. But on the right, historically, on this endoscopic image, many might have considered that penetration, even though it's the same part, same structure. We go a little bit further down, we're still on the floppy part of the epiglottis. Still, I think most people for the video X-ray probably wouldn't have called that penetration. I think historically on the right, the endoscopic image, many people would have considered that penetration. And as another example, we could go kind of between the level of the vocal folds, right? So in the dark band on the image on the left, many of us would say that's penetration of the vocal folds. And on the right, while it's still the vocal folds, because it's no longer on the top, many clinicians would have considered that aspiration because it's below the top of the vocal folds, even though it's not below the vocal folds. So there's kind of a lot of discrepancy just based off of the exam type, and that's not how this should be. We should be trying to line up these exams so it's consistent. So there had been a need to standardize FEES interpretation by developing clear anatomic and temporal boundaries, and that's essentially where VASES came in, which stands for the Visual Analysis of Swallowing Efficiency and Safety. So the article on the left, that was the first manuscript, and that's the manuscript that kind of goes over the rules in detail. And then we have a validity study, we have some normative data that have been published, and recently we have another study that combines VASES with another scale, which I'll get to. So the point of VASES was it was intended to improve standardization. It was intended to improve transparency. So standardization is important. It's really critical, but I would say it loses a lot of value if it's not transparent, right? So we could be saying the same thing, but not knowing that we're talking about different things. So I think standardization is good, but it needs to also be extremely transparent. So we're all speaking the same language and knowing what words we're actually saying. VASES is also intended to improve the reliability, the responsiveness, the validity, and also the generalizability, meaning from FEES to modified barium swallow studies. And so we're getting at kind of those top parameters by delineating very clear anatomic and temporal boundaries, which I'm going to briefly go over, but I'm not going to show it in detail because there's other resources for that. Using percentage residue ratings rather than categories, and that's actually very intuitive to use in clinical practice, and coming up with very clear ways of how we're going about doing these ratings, not just prescribing a number. And in terms of generalizability, the idea with VASES is that it borrowed a lot from video fluoroscopy so that the anatomic and temporal boundaries used to provide ratings are very similar to the ones that we also use for modified barium swallow studies and very popular methodologies that have been published out there. So VASES has 4 main kind of domains or kind of rules or parameters, and also some secondary miscellaneous rules that we have to deal with because it's FEES. So we have the what, when, where, and how of VASES. So the what refers to what is it that we're actually rating. Okay, so you did a FEES. We should be going back and reviewing our fees. We should be doing that if we want to bill for it, right? And so we look at a swallow and then we hit pause, right? We just looked at them take a 10 milliliter sip of water, hit pause. Now what do? Well, we rate these 7 different outcome measures, right? Pause, and then give ratings for these 7 different outcome measures. This is what we're rating. And doing that would take about 30 seconds to do. It looks like a lot, but it's very quick. So the idea is that these first 3 residue ratings are getting at pharyngeal swallowing efficiency. And then the next 3 residue ratings are getting at swallowing safety, trying to estimate the amount of penetration in the vestibular vocal folds and the amount of aspiration. And then also borrowing the PIS, but making that a little bit more standardized with our anatomic and temporal boundaries. So that's the what. The where of VASES includes the anatomic boundaries that are defined by VASES. So essentially looking at an image like this on a camera, but thinking about it like this, right? And so coming up with these clear kind of delineations of what is the oral pharynx, the hypopharynx, the epiglottis, the laryngeal vestibule, the vocal folds, and the subglottis. So going from here in our brain to here in our brain. We're not actually drawing these, we're thinking about it like this. So as an example, if we think about the boundaries for the oral pharynx, the way you would go about doing this, I'm going to do this very quickly, is for this structure, what you would do is you look at the points where the epiglottic folds merge in the epiglottis, something like this. You would then draw an imaginary line across the screen, and everything in front of it and at that level or above, highlighted here in yellow, would be considered the oral pharynx. And then within the oral pharynx, we have the vallecula, which is outlined here. And then we go into a lot of detail about literally tips and tricks about how you would do that. How do we define the vallecula? What things are we doing to come up with this curved line? And just like that, we would then continue that methodology for our other boundaries, including the hypopharynx and the piriforms, the free end of the epiglottis and the floppy parts, which for VASES, we don't say is penetration. So for VASES, to be more consistent with video fluoroscopy, we say anything on here, not penetration. Anything here is penetration. And so this would be the laryngeal vestibule boundary. And we talk clearly about how do we define this boundary, how far out or up do we go, or really kind of how far in do we go. We have the vocal folds, which include looking at the laryngeal ventricles, which we don't really see on endoscopy that well, the superior surface of the vocal folds, the medial edge, and also the space between. So this would be the vocal folds or the glottis, where notably with VASES, we say anything between the vocal folds, even if it's not touching the vocal folds, but it's at that same level, the glottis, we don't consider that penetration, it's aspiration. Or we don't consider that aspiration, it's penetration. And then we also have the boundary for the subglottis. Right. And so the idea is that these boundaries are lining up with the video fluoroscopy. So one, we have the oral pharynx, then the hypopharynx and the piriforms, the floppy part of the epiglottis, the vestibule, the vocal folds, and the subglottis. So we have the what are we rating? We have the where are we rating? We also have the when. So these are our temporal boundaries. And so VASES establishes 4 temporal boundaries. We have the before the swallow, during the swallow, after the swallow, and then between bolus trials. And for each of these, we have an onset and an offset highlighted here. So these kind of little markers would be the onset of the before the swallow, the offset of it. Then the offset of the before the swallow is the onset of the during the swallow. Then we have the onset, offset, onset, offset, onset, offset. So in the manuscript and some of the trainings I have available online for free, we go about how to define the onset and the offset of each of these temporal phases. And then we use that to guide our ratings. So our residue ratings are meant to capture one point in time, right? That would be a limitation of it. But the benefit is that we all know what we're talking about at that point in time. And so the offset of the after the swallow phase is where we do our 6 different residue ratings: pharyngeal residue, penetration residue, and aspiration residue. We also have our 3 different temporal boundaries for the swallow, before, during, and after the swallow. And then for that, we have a PAS. And then we also use that boundary to define what's considered silent versus non-silent aspiration. So if someone coughs a minute later, we're not like, well, was that silent or was it non-silent because it was a minute later? Right? So we have a clear boundary for silent, non-silent aspiration. We also have another PAS rating between the swallow, where then that's the boundary for silent versus non-silent. And then typically we report the maximum between those two PAS scores. Then we also have the how. So we've talked about what are we rating? We've talked about our anatomic boundaries and our tempo boundaries, the what and the when, and then how. And so here we go in detail about how do we actually come up with our residue ratings? How do we come up with the PAS ratings? And so for residue ratings, we're really guided by our anatomic and temporal boundaries. We use percentage-based residue ratings to describe the amount that's filling our oropharynx and hypopharynx. And then separately, we talk about covering for the vestibule, vocal folds, and subglottis. So kind of two different constructs for our anatomic structure. And then from there, we can either use a visual analog scale. Clinically, no one's going to do that, which is why we came out with our validity study, which looked at just coming up with a number. So you might look at this image and say, I don't know, it looks like around 40% of the hypopharynx is filled with oropharyngeal residue. So you just think of your number, you say it, and then you type it or you write it. And so it's pretty clear, right? You can say to your colleague, yeah, I gave them a 20 milliliter sip of white dyed water and it filled around 30% of their hypopharynx. Like we have a very clear idea of what that actually means rather than saying mild or moderate, or I don't know, like mild to moderate. It's a lot more transparent. We also have our penetration aspiration scale scores, which again, we use our anatomic and temporal boundaries, and then a lot of secondary rules, like what if we do on the fence about something? What if there's secretions there? What if we do if our lighting is not good? And we kind of go through all of that. So I didn't go into detail about it, but this is all on my website. So I have a website with a lot of free tutorials on there. And so that's like not me talking about me, that's Apple. And so you just go to tutorials, swallowing VASES, and there's a lot of free webinars, updated VASES notes, and some other things that I'm going to show you in just a second. Okay, so now that we know why we might want to use VASES and also what VASES is, let's talk about how you might actually integrate this into clinical practice. So I think the first thing is to come up and try to identify which swallows are you going to actually rate with VASES. Ideally, you rate all swallows in your standardized protocol. This would be ideal. This is what I do in clinical practice. It helps because I also have interns. But ideally, you have a standardized protocol that you've developed at your institution for your clinic flow. And you say, for these 10 swallows that are part of my standardized protocol, I'm going to be doing it, in this case, VASES ratings for every single swallow, which shouldn't be a big deal because to bill for fees, we actually should technically be reviewing the video. And so it's adding about 30 seconds to 60 seconds per swallow. And so it's adding about 10 minutes, but you're already doing the analysis anyway. So hopefully it's not too much. But it can be a lot on the front end when you're first kind of learning how to do these ratings, think about the rules, all that stuff. So you're going to be very slow on the front end. So you might decide, all right, I'm going to start off with maybe just one standardized swallow. So maybe I'm just going to measure, I'm going to do a rating for a self-selected volume of blue water or green water or something. And then maybe you kind of work your way up and do, okay, I'm going to do one liquid trial that I rate, and I'm going to do one pudding, and I'm going to do one cracker. I'm just going to rate 3 trials. And then maybe say I'm going to do all my liquid trials, and then maybe forget the rest for right now until you kind of get faster and faster, build up the confidence, build up the workflow efficiency until you're eventually doing all trials. So that's the first step is which swallows am I going to rate? Once you determine which swallows you rate, view a swallow, pause it, rate the 7 outcome measures. As needed, you might kind of scroll a little bit and then do your rating. So you might have a sheet like this in your report. Mine looks a little different now, but it might be something like this. So we see the protocol that we use at our institution that my colleague and I worked to develop. And so we might view the first 5 ml thin liquid cup sip and then pause it and then provide our ratings and then a PAS rating as well. Next video, right? Next video, move on, pause it, provide our ratings, just kind of how filled is all this stuff? You will be slow on the front end because you're going to be thinking about the rules and how do I do this and how do I do that. You'll also probably be like worrying, am I like interpreting it right? And so you'll eventually get faster and faster and more comfortable. So don't sweat the small stuff. Don't sweat the small stuff. What we found was that when we did this with graduate students, it typically took them about a minute per swallow. And I will say with interns that I've trained, with fellows that I've trained, it takes them less than a minute. It certainly takes me less than a minute. That'll vary depending on the complexity of your patient, but it doesn't take that long to do these 7 outcome measures. Once you've done your ratings, then what you would probably want to do, you don't have to, but what you'd probably want to do is compare to preliminary normative data. So about a year ago, we published norms using VASES, so VASES related norms. They're preliminary. They're from 39 non-dysphagic adults within the range of like 25 to like 80 something. But most people were kind of in like the 40 to 65 age range, but still only 39 people. But it is a place to start. So you can look up this article. When we go through it in the manuscript, we kind of provide an overview of the findings across the entire protocol that was done. But what you would want to do clinically is probably download the supplemental document associated with this. And in the supplemental document, we have norms for each individual swallow condition. So we have norms, all the liquids you repeated twice. We did it once with green opaque water and once with kind of like the white coating water. We did that across different volumes and patient per river volumes. We looked at puddings, we looked at crackers. And so you go to the swallow of interest and look at the norms there. So this would be an example of us looking at a 20 ml thin liquid water sip, and we can see a column for green opaque water and a column for white coating water. And these numbers represent percentile rankings. In other words, the percentage of healthy adult swallows that had a rating of that or less. So when we look at this, I'll give you practice in just a second. Traditionally, someone is considered relatively typical or normal if their percentile ranking is somewhere between the 25th to 75th percentile. If we're thinking, if someone is between the 5th and 25th percentile, or between the 75th and 95th percentile, we would say that they're mildly atypical, right? They might be normal, but it's not super normal. Maybe it's a sign of impairment, right? And none of this, we just do best guesses, right? We never know 100%. It's all kind of a continuum. And if someone is less than 5th percentile or greater than the 95th percentile, that's very atypical. It could be normal, but it's definitely unusual. And it's probably a sign that they're impaired, okay? So these would be ways to kind of think about impairment levels. I will say they're helpful clinically, but clinically, you should know it all exists on a continuum. And to say that someone who's the 94th percentile is mildly atypical and the 95th percentile, now they're very atypical, to me, that's a little arbitrary. So I take these categories with a grain of salt, but it is a place to kind of start and to kind of quickly think, but just don't get in the trap and don't sweat if it's like off by a percentile. So here we have a 20 ml white coating water, and meaning that it was 20 ml sip that they were given, and it was water that we added a lot of white dye to kind of give it that nice coating effect. And so let's say that that person swallowed, and we thought that 2% of the laryngeal vestibule was covered with residue, right? This is not uncommon for us to see. Then what you would do is you go to the supplemental document and you say, all right, 20 ml, that's this one. We're talking about laryngeal vestibule. So first of all, residue was present. All right, so 46.2% of healthy adult swallows had something in the vestibule after the swallow. So it's not completely weird that they have a little bit in the vestibule, that they have this PAS of 3. So then we're going to look at the amount when residue was present. And so here we see that their rating was 2%. And so what I'd recommend doing is not looking at mean and standard deviation, but looking at median. Q1 stands for 25th percentile and Q3 is the 75th. So we can see that for white coating water, most people were in the 2 to 6% range. This person is relatively normal, right? There was a little something there. It was a PAS of 3, which sounds maybe not normal, but the reality is that most people have a lot of people have something there, a little, about half. And 2% is, first of all, it's not a lot, and it's what most healthy adults have when they do exhibit penetration. But if we saw a swallow and it had 25% of laryngeal vestibule covered, well, now that's abnormal, right? The fact that it's there, not super unusual, but the amount is very atypical. In fact, when we look at, so certainly it's above the 75th percentile, it's above the 95th percentile. And in fact, for this cohort of people, no one had above 24%. So 25% would be like, everyone has something less than that. So this person has a lot when compared to healthy adult swallows. And so that's how you'd go about interpreting this generally. How do I do it specifically? Okay. I report all trials within our standardized protocol. I don't necessarily talk about strategies or extra swallows that we did, although I might when I'm kind of characterizing how efficient or not efficient a strategy was. I also use VASES, which is good at talking about individual swallows, to derive protocol level impairment profiles. And so we use digest fees on everybody. And digest fees, for you, those of you less familiar with it, would allow us to say something like the patient presents with moderate impairment in overall swallow function, with mild impairment in swallowing efficiency and moderate impairment in swallowing safety. So it allows us to kind of talk about the patient's swallow severity level, which I feel like a lot of us do, but in non-standardized ways. And digest fees allows us to do that. So this was the original digest fees publication, and which talks about the development of it and how to go about doing it. Digest fees was adapted from Digest, which was originally developed by Kate Hutchison and colleagues at MD Anderson for video fluoroscopy in people with head and neck cancer. And it's since been looked at in people with neurologic diseases as well. And I think it kind of hasn't been looked at in every single disease population, but I don't think it needs to be honest. I use it for everybody, to be honest. So this was the original Digest publication, and then there was a revised version of it where they made a couple of tweaks. But digest fees is based off of Digest. And so with digest fees, you come up with 3 grades. Based off of the PAS, you look at what was the maximum PAS seen across an entire standardized protocol. Let's say the maximum PAS was a PAS of 5. Then you say, okay, PS of 5. Now, let's see, how frequently did it occur? Was it a single event, not gross, or was it intermittent or chronic? And they define what is single, what is intermittent, and what's chronic. They define what is trace, what is gross, what is neither trace nor gross. And then from there, you would get a safety grade. So this just talks about at the protocol level, this person has moderate impairment in swallowing safety, for example. There's also an efficiency grade with a similar system where you identify the maximum residue rating across an entire protocol. Then from there, look at what consistencies we saw it. And then from there, you get your grade. Then to talk about the overall, kind of the total score, you would combine the two. So let's say someone had a safety grade of 2, so a moderate safety impairment, and an efficiency grade of 3, so a severe impairment. Then you would look at the kind of interaction between the two and say that their total score, their total digest rating would be a severe. So they have severe overall swallowing impairment characterized by moderate impairment in swallowing safety and severe impairment in swallowing efficiency. We recently published, as of like a week ago, that you could use VASES ratings to come up with digest fees grades. And so this is great. So if you're doing VASES ratings already for everything in your standardized protocol, you can automatically come up with these digest grades with no extra effort. And now you're getting information at the bolus level and also able to kind of talk about the overall impairment. So I developed an unofficial Excel spreadsheet that I'm sharing with all of you that you can use to auto-interpret our bolus level ratings, and which can also be used to auto-calculate digest grades. Yes, so essentially, you'd go to my website. You would then click on the tutorial section. You would then go to VASES. You would then scroll down to the section that says providing VASES ratings in clinical practice. And then there's a link right there to show that you can use to download that Excel spreadsheet. And then there's also a video here that kind of walks you through how to use the Excel spreadsheet. It's about 15 minutes long. But essentially, there's two worksheets to the spreadsheet. You'd click on the database worksheet first. You would then fill out identifying information as needed. You would adjust the protocol as needed. You probably shouldn't adjust the protocol because it might affect the calculations. So this is a starting place for you. You can use this, but if you aren't using this protocol, it might not work correctly. Then you would enter your VASES ratings, right? And so this is, I think, an 11 trial protocol. You would enter your VASES ratings here. Once you do that, you would then click on the form worksheet, and that's then a form that you can copy from Excel and then paste it into your electronic medical record. So this is what I do when I'm seeing a patient with fees, myself, or maybe one of the interns or clinical fellows that I work with. They would enter their VASES ratings, go to this form, highlight this whole thing, and copy and paste it into our Epic report. And so what we have here, just to acclimate you, is we have our outcome measures, our VASES ratings, along with number of swallows. And then for each one of those ratings, we also record bite sizes and sip sizes, which I highly recommend you do too as well. You can just use a simple food scale. Okay, so for each of these outcome measures, we have results. So that's like our raw VASES rating. Then next to it, we have our interpretation, our auto interpretation of the normative data. So percent would be the percentile rankings that I previously showed you. So for example, if we saw that the person did a 20 ml white thin liquid sip and they did it in 2 swallows, then we see right next to that 65.6, meaning 65.6% of healthy adult swallows did this in 2 swallows or less. So they're relatively normal. They didn't do a lot of swallows necessarily. If we looked at their laryngeal vestibule rating, we might have said, oh, it looks like it's covering around 9% of the vestibule. Well, 86% of healthy adult swallows, when there is penetration into the vestibule, have a rating of this or less. So it's, it's a little atypical. If we looked further down and we looked at their self-selected volume, here it's covering 67%. And so here, this is really unusual. This is a lot of residue. 100% of healthy adult swallows have a rating of this or less. So this person is on the high end of that. We could look at aspiration. So this would be the same thing. They have subglottic residue. It covered around 6% of the subglottic shelf. And when aspiration is present, right, so this is excluding all the absence, this is a rate like 35.7% of healthy adult aspirated swallows have a rating of this or less. So this is relatively normal. And then in terms of PAS, a PAS of 8 is not normal. 100% of healthy adult swallows had a rating of this or less. So this would be on the extreme end. What I also did with this Excel spreadsheet, so you know, is that the interpretation is in a lighter gray, so it doesn't pop out quite as much. And when something is in the very atypical range, I've made it so that it's red, so that it pops out a little bit more. And also for airway residue ratings of 0, I've made it so that it doesn't show up. So they're not left with so many numbers so that things can pop out and you can see things a little bit easier. So this would be the auto interpretation of our VASES ratings, and then the digest scores would get calculated based off of that. Again, this is protocol specific. So if you alter the protocol in the Excel spreadsheet, it's likely going to affect this. I need to review that in detail. But we can see here that with those ratings, this person auto-calculated that they were severely impaired overall with severe impairments in safety and efficiency. I should say that for this protocol, if you do use this protocol, that very first 5 ml thin liquid sip is not part of our digest ratings, and the 90 ml sip is not part of our digest ratings. Everything else is what gets integrated into the digest scores that we do. So you'd copy and paste that. All right, so to essentially wrap things up, this is the last thing I want to talk about, is not just how you are going to kind of analyze it, but also how you talk about this in clinical practice. So it's very intuitive. I think it sounds like with these numbers, it might not be, but it's very intuitive. So instead of saying, if we're talking about pharyngeal residue, instead of saying something like patient presents with moderate amount of molecular residue with puddings, which cleared to trace amounts after 2 to 3 swallows, we could just as easily say that they present with 40 to 50% of the vallecula filled with oropharyngeal residue, and that's cleared around 5% with 2 to 3 extra swallows. Super clear. In terms of penetration, instead of saying patient presented with intermittent penetration into the vestibule, but remaining above the vocal folds, we might say patient presented with intermittent penetration in the vestibule, but remaining above the vocal folds. And when it was present, it covered around 30 to 40%, right? And in terms of aspiration, instead of saying something like patient presented with aspiration of thin liquids, with two events being silent micro amounts and one event being a non-silent gross amount of aspiration, we could just as easily say that 2 of the aspiration events were silent, covering around 2 to 10% of the subglottic shelf. This would make sense. This would we expect. And 1 aspiration event which had a cough, it was non-silent, and it covered around 60% of the subglottic shelf. Okay, so one last resource for you all would be to consider to go to my website. You don't have to, it's just free resources. So jamescurtisphd.me. Click on tutorials, swallowing, go to the VASES. And here we have an overview of like what VASES is. This is like a 2.5-hour training webinar that I did on like specifics, like how, like what's the method? Like how do I come up with these boundaries? So you can view that, and you will also see that there was a previous, like our original webinar that we did years ago now that was around 1.5 hours. So there's a couple of like detailed trainings you can look at there. There's some interpretation practice where we go through some videos and kind of like calibrate your eye to what it is that we're seeing. Certainly we have the Excel spreadsheet and the video that takes you through that Excel spreadsheet. And I also have clinical examples of how you can write this in your reports. And also I have, like, if there's updates on VASES before it goes to kind of the manuscripts, I might be putting it on this website so you can kind of think through things that might be unclear. Okay, so we're gonna wrap it up. I'm gonna end with one last poll. Would love to see if anyone is still there. It looks like people are still here, wow. Go ahead and scan this QR code, and I would love your honest opinion in terms of this statement now. So I have a generally good understanding of why and how to use VASES in clinical practice for interpretation. You don't just have to say this to make me feel good. This is me feeling uncomfortable with being uncomfortable, as we all should be. Great. Well, I'm glad to see that it's skewed, but now it's skewed towards the other end. Hope you all learned a lot. I hope that you feel like you've got a lot of resources that are available to you. I would say that when people start doing VASES, you're gonna feel like you're getting in the nitty-gritty, and you're like, I don't know, like, is this the boundary? Is this the boundary? And you're getting at like the pixel level. And I say, that's awesome. I would say, don't sweat the small stuff. I would say that the ideas that we're going from being not specific at all to being much more specific, but we're never going to be computers and agree on the exact same pixel, right? I would also say we're not going to agree on the exact same residue rating number or even the PAS rating. But the idea is that this is helping us become a lot more reliable, but we're not going to be perfect. So don't worry. Don't get stressed out if you're not agreeing with maybe what I say on videos or with what you're saying with your colleagues. As you start to learn and practice this, if you choose to do that, I will say that the trend is for people to have higher residue ratings, and then they slowly, with experience, start to have the residue ratings be less and less. And I think because a lot of times people start to think about severity, and then they realize it's not about a severity impression, it's about objectively estimating how filled is something or how much is something covered. And it's not about like, do I think it's abnormal? Do I think it's bad? Do I think it's not? It's not about that. Definitely review the secondary, those kind of miscellaneous secondary rules. Those are really, really critical. They're not less important. They're very important. They're just miscellaneous. So review those, review the webinars. Hopefully it helps. And Thank you for your time and attention, and I'm happy to answer any questions at this point. And I'm so sorry I'm behind.
That's okay. Dr. Curtis, we had a question specifically about, let me scroll up real quick. It was from Emily. Okay, she said, can you provide further information on how you're determining what is a significant difference in terms of VASES scores over time? For example, is a 5% difference significant, or is it potentially reflective of normal test retest variability within a patient?
Love it. Yeah, we need more research to know what a minimum detectable difference is. That is a good area of research that will probably be like 5 years down the road for us to actually know. I mean, I would think like 5% is not a big deal, to be honest, but who knows? Who knows? And maybe it's region specific, right? So maybe a 5% difference for aspiration, maybe that means a little bit more than a 5% difference for oral pharyngeal residue, or even penetration, but I don't know. I don't have the answer. I think you could probably look at the normative data and say like, okay, a 5% is actually a really big range in some of these structures, but for other structures, it's minuscule. So I don't know. I would think for healthy adults, it probably means a little bit more because we have typically a lot less residue. But for someone who's really impaired, if we're fluctuating by 5%, it's probably like variability for them and not a huge difference. That would be my thought, but we need more research. So I think it's kind of person specific. For people with not a lot of residue, probably a bigger difference than for people with a lot of residue.
We have a couple more questions. So this one is, would you find it helpful for colleagues to watch FEES videos together and fill out a VASES form to calibrate ratings within the department? Or is that too much of, quote, sweating the small stuff?
No, I think it's great. I think calibration for any sort of a perceptual assessment that we do is really critical. I think that includes auditory perceptual assessments of voice. I think auditory perceptual assessments of cough. I think visual perceptual assessment of PAS as seen on video fluoroscopy. I think visual perceptual assessment of FEES. I think anything that's perceptual in nature, I think calibration meetings are really helpful, at the very least, so you know how your colleagues rate things. But I think talking through these ratings helps us to kind of calibrate and get us kind of on the same page. The caveat being, maybe your nest of colleagues is going to be viewing things very different than at another institution if we're not, but it's, we just do what we can, where we can. And it's part of the reason why I've been trying to upload more and more interpretation ratings on my website. So there's like some sort of like central place, but I am not the be all end all. I don't have any magic eyes that other people don't have. So yeah, I say feel comfortable calibrating with colleagues if you can somehow make that time work.
Awesome. We have one more question that we'll
Totally
answer.
fine.
It might go, you might only be able to kind of give a preliminary answer, but
Yeah.
we'll go for it. Someone asked, how do we use VASES to guide treatment?
Okay, so I think that some of it relies on I would use normative data in part to kind of understand what's really abnormal, what's not. I think when we are thinking about, first of all, if we do treatment or not, we think about a lot of factors, not just what is it that the fee shows, but also patient desire, their medical status. And so, you know, a 10% aspiration subglottic residue rating might not mean a lot for a healthy adult who has a good cough, but for someone with a bilateral lung transplant, probably a bigger deal. And so I think we have to kind of take the whole patient in perspective in terms of treatment or no treatment. In terms of determining what, like, we see these patterns of residue rating, so which exercises do we do? I don't think FEES tells us that. I think that, this is another lecture that I give a lot, but I think our instrumental assessments of swallowing only tell us half the picture. And I think the other half comes from our clinical assessment. I think our clinical assessment helps us to get at why are there impairments to begin with? Is it an impairment in sensation, skill, strength, anatomy? And so I think the clinical assessments help to tell us how we want to go about doing therapy. Do we want to do a skill-based therapy, a strength-based therapy, a stretching-based therapy? And I think to know what we want to target, typically we want to be thinking about the physiologic impairments. And so we need, I think, video fluoroscopy or fluoro for that. I mean, or manometry for that. And if you don't have access to that, then we're kind of throwing darts in the dark. And I think that might be okay. It's not ideal, right? Ideally, everyone had video x-ray. But if we don't have that, then I think the approach to consider understanding that we might be missing things that are like anatomic, like bars that are actually more surgical in nature. But if we don't have that and we have to do something, then I would say what you can do is trial a course of therapy and be systematic and say, all right, let's do a 2-month block of therapy. Now let's repeat the fees. Are we seeing changes or not? If we're not, then let's try another exercise or two. Let's switch some things out. And now let's go through another block of therapy. Now let's repeat the fees, right? And so you're seeing, are there changes or not? But I don't think fees tells you what specific exercise to do. I think you need fluoro to understand what kinematic impairments you're targeting. And I think you need the clinical assessment to tell us how to go about targeting those clinical impairments. That would be my thought. But
Awesome.
that's expert opinion. That's like, don't, crucify me for that. Or shouldn't say crucify, yeah.
Well, Dr. Curtis, thank you for this incredible presentation and for spending time answering some of the questions after the presentation. For those who asked questions in the chat, I did link Dr. Curtis's website in the chat, and we will put the link on our website too, so you can click on it from there. The replay, like I mentioned, it'll be emailed out to all of you as soon as it's done uploading to the cloud, but it'll be available on our website. And then the survey, because we had some questions about that. The link will be live as soon as we log off of the Zoom. It should be emailed out to you automatically, but you can also access it via your registration link. So just go back into that and access it, and it'll be available until next Wednesday. So with that, we will conclude our presentation this evening. Dr. Curtis, thank you so much. And thank you to everyone who joined us this evening.
All right. Thank you, everybody. Good to see you, kind of. Okay. Bye.
Bye.
Bye.